This is a technique video for diagnostic evaluation of the knee in the office setting using small bore needle arthroscopy. Here are our disclosures. Arthroscopy is currently the gold standard for diagnosing intra-articular knee pathology. While MRI can be a useful diagnostic aid, it is not without its errors. In-office arthroscopy offers an alternative and supplementation to MRI. The patient should be positioned on the office table with the knee in 90 degrees of flexion. This can be done with the patient seated or supine with a bump at the foot, per the surgeon's preference. Each position allows the surgeon for potential of a dynamic exam if needed. The lateral, medial, and inferior border of the patella should be palpated and drawn out along with the patellar tendon. The medial and lateral portals are drawn out just off the patella tendon medially and laterally 0.5 centimeters inferior to the inferior pole of the patella. A transpatellar tendon portal 1 centimeter inferior to the inferior pole can also be used if necessary. If further evaluation of the patellofemoral joint is necessary, standard superior lateral or superior medial portals can be utilized. The site can be prepped with sterile triple betadine preparation. 30 cc's of 2% lidocaine without epinephrine should be drawn up sterilely. 1 to 2 cc's per portal and 20 cc's into the joint can then be injected. Allow 3 to 5 minutes for the analgesic to take full effect, ensuring adequate analgesia utilizing a pinch test. Reapplication of antiseptic to the area should be performed immediately prior to inserting the MyEye probe into the joint. Ensure you have at least 10 to 20 cc syringes full of sterile saline before beginning the procedure. Remove probe connector and hand to the assistant to be plugged into the tablet. Insert the probe into the medial or lateral portal sites, making sure to aim at the notch to avoid injury to the cartilage and menisci. Once in the capsule, depress the retraction button and retract the needle, exposing the probe optics. The stopcock should be open to allow for injection of saline. Slowly inject saline to distend the capsule and fill the joint for adequate visualization. Bursts of 3 cc fluid will be required to push away soft tissue and allow for visualization at specific times. This is a picture of the notch. As you can see, the ACL is crossing the image. The figure of 4 position is utilized to adequately visualize the lateral compartment. An assistant applies the valgus stress to the knee in order to visualize the medial compartment. The knee can then be extended and the probe can be placed in the patellofemoral joint. After completion of the arthroscopy, the fluid in the joint can be aspirated through the same stopcock using a 50 cc syringe. Upon removal of the probe, a compressive dressing should be applied to the knee, such as an ACE wrap. The images are saved to the portal can then be reviewed with the patient immediately following the procedure. Thank you for your time.